Please take your seats so we can start this third round table. Bueno, no hace falta. Bueno, lo dejo encendido. Claro, lo digo porque sí, ¿no?
Sí, sí, vale, no, pero es fácil, ¿no?
Sí, sí.
Sí, sí, claro, sí, lo llevamos sufriendo.
Mi general, con su permiso. Now we have the third round table. It's about military support to European vaccination plans against pandemic. It's going to be chaired by Colonel María del Carmen Ibarra. Please, Colonel, the floor is yours.
Thanks. Sorry. Thanks for coming, because I understand that this afternoon, this sunny afternoon, should be better to be walking around the Madrid streets instead of stay here. But thanks. So I am a medical doctor, post at the Air Force Medical Directorate, and I have the honor and pleasure of being here this afternoon at this after session. The different lectures that and the subsequent discussion will focus on the military support provided to vaccination plans during the current COVID pandemic. Let me introduce you the speakers this afternoon. In the last corner, we have Captain Leticia Escudero, psychologist at the Institute of Defense Military Preventive Medicine Institute. Besides her is the Major Martin von Innis, also is pharmacist, and she comes from Belgian Army. Besides her, Colonel Luc von Paris, also a pharmacist. Lieutenant Colonel Sophie Dallas comes from France, and she's also a pharmacist. We have also Genma Colmenar, a Spanish captain, and she is a nurse. So, and last, we have Colonel Carmen Ariñez, head of the Institute, Defense Military Preventive Medicine Institute. As you can see, we have really, really diverse speakers. So we will have a wide approach to the vaccination plans that is not one thing from pharmacists or medical people. It's something that covers all the aspects in the medical health systems, and for sure in the military. So let me start with Colonel von Paris.
Thank you very much. Can anybody hear me? Yes. I have the privilege on this sunny afternoon, after this nice lunch, to try to wake you up again and get you enthusiastic for this vaccines. So, generals, commodore, colleagues, I would like to thank you to give me this opportunity to speak up about this nice subject. I think that the proof of the pudding is in the eating. So my presentation will go on a much lower level and I will talk about on what it means when your boss says to you, make it happen. So I will talk about COVID-19 vaccines transport for multinational operations. So if you allow me, I would like to talk about the points you see. Multinational operations, where the Belgian army is involved, of course. These vaccines, then planning elements for a vaccination campaign, transport equipment and qualification work, minimum GDP requirements for transport. As a pharmacist, I know what GDP means, that is good distribution practices. And then 3 case studies and some conclusions. So, multinational operations, where I will be talking about are the operations from the period January-June 2021. This was the period where we have Belgian personnel deployed without vaccination. So we had like some 100 people in ODF, that's in Jordan. We have 2 vessels in the Baltic Sea and in the Middle East. We have this army operations in Lithuania, Mali, and two in Mali, and 1 in Special Forces Para in Niger. You see the numbers of the people involved next to on slides. These are not large numbers, but it doesn't have to be large numbers to make it more or less difficult. So, the COVID-19 vaccines, there you see them, the 4 arriving. The first one came, the first conditional marketing authorization. This doesn't mean that you have a vial in your freezer, but the first marketing authorizations arrived there in the beginning of 21. And in Belgium, it was that Belgian defense could not buy its own vaccines. There was a national vaccination strategy, a national acquisition via Europe. So I will not go into all these details. But in the national vaccination strategy, the people had no choice. It was still voluntary basis. It was only the EMA-approved vaccines that could be used. So no Covishield, for example. And then with time, the strategy was updated. It's important for this, for us. In the beginning of April with this no AstraZeneca for this age that was of particular interest of the military. And then the no Johnson & Johnson below 41, unless consent. So marketing authorization is one thing. Having vials is another thing. So the vaccines came very slow. Started with Pfizer, timing, type, and quantities. Like in the beginning, if we gave 1 Pfizer, we had to keep the second dose in the freezer. So this was with a treat. You kept the half of your vaccines in the freezer. You could not start giving your first dose because you simply was not sure to have your second dose. Yeah? And Belgium is a special country, not big, but we have 4 states, regions in Belgium which receive their weekly quota. And that was a particular situation. So for the military medical personnel was vaccinated with the other medical personnel, civilian medical personnel in Belgium. They all received their Pfizer as the other doctors and nurses and things like that. For the military personnel in operations, it was a bit more difficult. It required some more negotiation because this meant you will give a dose to a healthy person and not to an elderly person that probably will die if he gets COVID. So this was more, and what we were able to get some vaccines for essential functions in the national vaccination strategy. So this required some lobbying. So, more practically, so planning elements for vaccination campaign. I will talk about transport. Yeah, that's my domain of competence. But a vaccination campaign is quite simple. You need a Belgian vaccine, a vaccinator, and your population at risk at the same place, time, 2 times. That's quite simple. So this planning is a national responsibility. So all planning was done at the Belgian ComOpsMed, the command of the medical component. So one of the things at the same place and time for these people that were already deployed, this means that you have to transport the vaccines to the people. Yeah? And so you have these 4 vaccines. The transport is determined by the vaccine characteristics. So like you have one that only needs 1 dose. So that was my preferred option, but we never received that. So not for the operation. So this means that for operation we got the AstraZeneca to start with, and later we got Moderna. Yeah? So this means that you have 2 doses, the different intervals, a minimum number of doses per vial. This means that if you open a vial, you must make sure or try to have a sufficient number of people around that vial, because after 6 hours, I think, you see the shelf life after puncture, your vial is lost. And this in a period where everybody in Belgium is waiting for his injection. So this, I mentioned this, we had a vaccine transport from Belgium to the vaccination site. Like somewhere where we stop, there the people will have to be. So we did not have any secondary transport in the theater. Yeah? This requires some coordination of having all your special people around that file. So it still is a medical act, injecting something into somebody. So we always had a medical doctor from ComOpsMed, so from the next to my door, yeah, who was prescribing the vaccines. So these are nominative lists. This before we could send vaccines out. We had to know who would receive these vaccines, and there was an assessment of the local setting that was: is there a doctor? Is there a nurse? How many people will we get there? Is there medical support in theater or not for secondary effects? So that was what we did in ComOpsMed. So one of the things, you have your number of people, your population at risk, and your theoretically number of doses per vial. But one of the things that was quite stressing was, you might remember that like for Pfizer, we start with 5 doses per vial. But after some while, we knew that you could get 7 doses in a large vaccination center. That is no big deal. But if you have to send a number of vials out, this has to be sufficient. And like we started with the AstraZeneca, and there the syringes were very determining for the number of doses you could get out of 1 vial. This could go from 10 to 12, depending on the syringes. That's why I show this picture. So also, sending a first and a second dose in one transport depends on local situation, dose interval, remaining shelf life 2 to 8. Another, I will go into more detail in the case studies on that. Another thing very important is this registration and vaccinate. Does the people want their digital COVID certificate when they come back home after their operation, so they can enter Spain or whatever. So this has to be dealt with also. And also from a medical point of view, when we had a vaccination campaign, there was the recommendation to have a low ops period, the 48 hours after, and there was surveillance with the periodic reporting we have always, but we never saw some major issues. So, transport, I will talk about transport. So you need transport equipment and you have to do some qualification work. Yeah. So what we had in the beginning of 2021 was this big Electrolux boxes. These are like this. You cannot see the size, but for transporting 4 to 10, 20 vials, it's a big box. Yeah. We had this golden hour. This is that arrived. Luckily, that arrived in the beginning of 21. This is a small case. It's like a suitcase of a lady. Yeah, so that was our favorite. Then the VacuTech. That was our only device we had for -20 transport at that moment. And then we had this active device, the Fiocchetti, that you could plunge into your vehicle if you wanted, but we never used this to transport, only for minor road transport. You cannot, we never used an active device in an aircraft, always passive device. So I use the word work, qualification, work. This does not grow on trees. This means that you have to have full-time equivalents to write procedures, to establish this guaranteed time, I call it. So you know for each box the theoretical time that he will keep between 2 and 8. It's not difficult to do this, but you need time to do this. You need data loggers. You need, and then you also have these ISTA standards from the vendor, where you have more extreme conditions and things like that. So GDP, good distribution practice. This means that you have a quality document management system, and you have also to train the people to work with these boxes. Yeah, this is also one of the problems we had in why we did not do any in-theater transport. Yeah. You also need to consider your freezers, and the fridge where you will put the vaccine in once he arrived. Yeah. So, qualification report. This is a typical document from our quality management system. So this requires 3 signatures, review, approval, and once, as I am the responsible person, GDP, qualified persons, with my signature, this means if you do this, you're okay. Okay. This is the qualification report. So this vacuum proof, for example, here you see with this phase change material, it typically will remain stable for a long time. It's like 4 days or something. And then it will rise very quickly. So this time here is a very important planning element when you talk about transport. So, okay. And then you need to write an instruction on how do you have to fit this. People have to know how to do it. Huh? So, GDP requirements for transport. So you get the message make it happen, transport GDP-wise the vaccines to wherever I tell you to transport them. So I think that you need 3 essentials as a minimum. So you have a risk assessment of the transport lane before you start anything. You have to establish a chain of custody, and you have to monitor the temperature and release the transport. Somebody have to say it's okay. Then this central coordination, it's typically GDP, but you could call it a process if you want. But you need one truth, only one truth. Not 15 people's having an idea. It was good, it was bad, it was maybe, no, one truth. Yeah? So, risk assessment. Yeah, we don't have aircrafts in the medical component, so you have to check flights. And with the flights, try to have these people around this vaccine when he arrives, or have a ship in the harbor and not a week before or a week after. So this, and compare the theoretically total transport time versus this guaranteed time you have of this passive device. Yeah? Once you close the device, the box, in Brussels, yeah, it stays closed until it is opened where you will vaccinate. Yeah? There's no, if you need two different places, you will need 2 boxes. Okay? Chain of custody, you have to know before who will take all the handovers. You have to know the names of the people that will, it's not like, okay, it will arrive at the airport in Bamako somewhere, and somebody, with fingers crossed, will come and take it. No, you have to know a name and how to contact this person in Brussels. Yeah. And it's very a formal way, so they need to sign batch number, name, date, time, yeah? And typically, that's what I always ask for, 2 eyes on the box. This means that you have to have somebody on the plane that cares about your box. Yeah? We don't have dedicated planes, so you might have a Falcon that is making his round with several stops, but you need one person that, with his name, with his cell phone, and that you're sure that he will take care of your box at every time, whatever happens. Yeah? So without this, I do not agree with the transport. Yeah? It's a bit complicated when you have quarantine requirements for flights. Yeah? So all these handover takeover documents need to be sent to the RP, the responsible person, during the transport. So the assessment of the temperature monitoring data and release of the transport, so it arrives. You know who will receive it. They have to take the data logger, press on stop, yeah, plug it into their laptop and send it. And then before injection, but you have to know, most of the time people already with their arm like this, please give me the vaccine. Yeah? But before the vaccine, whatever time, so the RP, so me, yeah, will assess the data. I know what happened during the transport, and I will write a formal release, a kind of message you see here. With this, the vaccines are ready to use. Yeah? Then with some more instructions, depends on the situation, but there is a clear message, you can use the vaccines. Yeah? And then you compile the full transport dossier and you archive that you can do afterwards. Yeah? So I go to these case studies to demonstrate the complexity of these kind of things. So we had in Belgium for a medical evacuation policy. As soon as somebody was COVID positive in theater, he would be evacuated back to Belgium. And so like in the beginning of January, we had this paras for in Niger, where we had to evacuate half of the people because there was positive cases. So this accelerated, I think, the having vaccines available for military personnel. If you want to continue with your operation, you might consider to vaccinate them. Yeah? So it was AstraZeneca. AstraZeneca means 2-8 transport. We had we needed 2 flights because we had people in Niamey and then a second flight to Maradi. So you have to calculate it. So 2 vaccination sites, that mean 2 boxes. You see this picture here with this Electrolux and a Falcon. It's a very big box for a very small number of files. Yeah. We knew 4 days, and then the second box continued. We had this, for this first transports, we had this Verigo catalogue that where our 2 eyes on the box had an idea what happened in the box. So without opening it, yeah, on his cell phone, he could read the temperature. So you see it here, this is the 2 eyes on the box, and this is the Belgian medical doctor, Maradi. This is the second flight. So the second dose of this AstraZeneca, for this we need to have a second transport, because at that time the interval was like 84 days. So the second transport was mid-June. You might remember that we could not give AstraZeneca anymore, but for the second doses we still could. Yeah. Second case study. So we had this update of the Belgian vaccination strategy, where we could not, and we follow, Belgian defense follows the national vaccination strategy. No more first dose of AstraZeneca vaccine for Belgian personnel and operations. So nice. This means that we had to switch to Moderna vaccine. And we were lucky because our VacuTech transport box was not qualified yet. So we did not know exactly what the box would do. So we had to do it with a 2-8 transport. And the company allowed a 12-hour 2-8 transport within the 30-day shelf life at 2-8. So we had a window. So once you get your Moderna vaccine out of your freezer, this is your time 0. Then you have 12 hours to get it where it has to be. Yeah? That's quite close timing. So here we decided to have one C-130 flight, Brussels, Kaunas, Tallinn. So the Kaunas was for the enhanced forward presence, Lithuania, and the other one was for the Rhodesia that was at that time in Tallinn, Estonia. So here you see on this picture the handover, takeover of this golden hour box. This is the golden hour. This is the size of this box. And then the vaccination and the picture of the Rhodesia. So it was one flight, but still it was different. So Lithuania, 2-8, 2 time windows, shelf life 30 days at 2-8. They had a fridge in Lithuania on solid ground. This is important because this adult Moderna vaccine cannot cope with mechanical stress. So You cannot put it on a ship, for example, that will be navigating, yeah? Even if they have a fridge. So here you see this 2 eyes on the box. This is there is somewhere is our golden hour between the rest. A bit complicated because this quarantine requirement, this person had to be 2 weeks in a hotel before. So just to give this 2 boxes. Okay, so the other one, the Rhodesia and the Baltic Sea. No mechanical stress, so we decided to split the shipment of the second dose, which we did not do for the Lithuania, where we have 30 days shelf life, 2 to 8, second dose after 28 days, so it's within the time frame. So here, on a ship, this is not possible. So we had a second transport, where the ship was in Warnemünde in Germany. At that time, we had our Vacutech transport box qualified. It's much more easier, no time constraint. You have this, the 2 eyes on the box was the medical doctor that did his rotation, so she was in quarantine anyway. And you arrive, you thaw and inject. Very easy. Last one. On Sunday morning, 2 eyes on the box. The C-130 is on the ground in Murcia with a battery problem. It's always on Sundays. So they had 2 golden hours with second dose AstraZeneca vaccines for Bamako and Hao. So the coaching from Comosmet, Belgian Comosmet, was still as repair timing was unsure. You have to decide very quickly. And we decided to open the box. So this is what we did. Okay. So I maybe explain. Yeah. So very quickly, so you have this first stop, second stop, Bamako, Hao, golden hours. So the 2 eyes on the box, what did he have to do? He have to take the boxes out of the plane, not leave it days on the tarmac. Yeah? Look for a fridge, look for a freezer. So open the 2 boxes and put the vaccine in the fridge. The other data logger he used to check for the freezers. It wasn't the freezer we used that is on the picture. It was the first one was not okay. Then when you know when your plane will start again, you refit the boxes, but the flight planning changed, so you have to consider carefully where you put your data loggers, but because you only have 1 data logger that has the 2 to 8 data for your vaccines. And this one you have to put in your first box that will arrive first. So, so when the box arrived in Bamako, you know what happened with your vaccine. Also for the one from Hao, because this data logger you used to have to check these freezers, so you don't have this data for this period, so you use the ones from Bamako. So, conclusions. So Belgian defense vaccinated Belgian population at risk with its Belgian vaccines. We're talking about multinational operations. So I think that probably every nation did the same, although I think that synergies were possible in all mentioned regions, like for this transport. Limiting factors. You plan the return of your boxes, because once they got their vaccines, nobody cares about these boxes, but you don't have much boxes. Another factor is the freezer. when you have to do a lot of transports for the vacuum tech, it takes 72 hours at minus 25 to have your cooling elements freeze. If you have to do 10 transports a week, you will need a lot of freezers. Yeah? And for the next, we would like to do some robustness tests. So if you are working in suboptimal conditions. Yeah? So, no vial was lost. We could vaccinate everybody we wanted to vaccinate. And I will be happy to take questions. Thank you.
We will let the questions for after, just in order to be more. So next one will be Lieutenant Colonel Martin Banis, also a pharmacist, and also in the Belgian Army. And she will address the contribution of the military pharmacy of the Quick Astrid Hospital to the national vaccination strategy against COVID.
Good afternoon, generals and ladies and gentlemen. I have the honor to present you the pharmacist contribution to the COVID-19 pandemic. I am the head of the pharmacy in the military hospital in Brussels, and I will take you to Brussels now. On the agenda is the vaccination strategy in Belgium, the role of the military hospital, the role of the pharmacy, and we will be a hub, a supplier to the vaccination. There will a little bit statistics and also the flow of the vaccines. And then I will have some conclusions. So Belgium, it's a difficult country. We are divided in 3 regions, I will say. So the blue one is Flanders, the green one is Wallonia, and the little pink one is Brussels. The military hospital is based in Brussels, so I will talk always for Brussels. The vaccination campaign was rolled out at the federal level. That was called the task force, where there was always a military delegation also. And first of all, they gathered logistic informations like the capacity of ultra-freezers, of refrigerators, the capacity of temperature monitoring, and also the capacity of space for a vaccination center. After that, they written the procedures and other useful information were available on a website that was only accessible for healthcare professionals. After the supply chain was mapped, the plan to the vaccination campaign was launched. Oei. I will do it otherwise. Voilà. So the task force said that there was a vaccination strategy in 3 phases. So the first one started in January with the phase 1A. There were a few vaccines in stock. It was a complex storage of the vaccines. It was Pfizer. And it was for the nursing homes, the collective care institutions, and also the healthcare professionals. As of March, we landed in a phase 1B. We had a lot of more vaccines in stock. The storage was less complex, so we could start the vaccination of the people aged above 65 years. The people above from 45 to 64 years with well-known risks, and very important for us as military. It was the people occupying a critical function in essential sectors. So the militaries were there. And as of May, we could start the phase 2, and then that was the vaccination for all adults above 18 years old. What was the role of the military hospital? First of all, we were one of the 31 Belgian hubs, and the military hospital in Brussels was a hub for the Brussels capital region. We were chosen by our capacity. We had 3 freezers at minus 80 degrees. So we had a storage capability of 25,000 vials of Pfizer. So that was big enough for Brussels. We had also a big fridge room, so we could also doing the towing process. After that, the military hospital was also a supplier for the vaccination of her own personnel in the hospital, the military personnel, expats, diplomats. We were also an example for NATO, EU Commission, and the SHAPE. And then the biggest population that we had to vaccinate was our Brussels capital population. Here you can see what was the task for the pharmacy. In the beginning, as hub, we had mostly logistic work. And after that, as supplier for the vaccination, we had always the logistic work. But now, from now on, we prepared also the vaccines. So the role of the pharmacy as a hub was doing a supply toward external, non-military establishments. Therefore, we had to adapt the task for procedures to our own establishment and also to our clients. We had to store and preserve the vials, controlling the defrosting process, transport them. It was not as military that we transport them, but we had to prepare it for transport and then ensure the traceability. As you can see, we had a few nursing homes of Brussels. It was not all the nursing home of Brussels. We had a few collective care institutions, but we had all the prisons of Belgium. We worked always with Pfizer for the non-military establishments, and so we delivered about 40,000 doses in Brussels and the prisons. All that was above our routine work because we have a burn unit. So we needed extra personnel to help us with all the logistic work that came for the supply towards the establishments. Here is the supply chain during the phase 1. So it was Pfizer that delivered the vials at minus 80 degrees to the hubs. There the hubs received the orders of the nursing homes, and then it was a federal contractor, here it was Medista, that did the transport at 28 degrees to the nursing homes. And it was the nursing homes that were supposed to deliver us the prescriptions. That was not the case. So here you can see a photo of our towing process. It was our Pfizer vaccines. And that was my team, one of my pharmacists, 3 of my pharmacists that were doing the defrosting process for the nursing homes. It took a lot of work and a lot of time to do it in the beginning. It was a high workload. Then the role of the pharmacy as supplier for the vaccination. We had several target groups. We had our own personnel of the military hospital that we vaccinated with Pfizer. Then we had a few patients of the burn units that we vaccinated with Pfizer of Johnson & Johnson. Then, as I said, the phase 1B, we were able to vaccinate the critical functions, so the first line professionals and the personnel for the missions abroad. That was with AstraZeneca. And then the personnel already in mission abroad, that was AstraZeneca or Moderna. So that was the presentation of the Colonel van Parijs. So then the vaccination center in the military hospital, as you can see, that's Belgium. We're gonna look at Brussels. We have 1 million citizens, and the Brussels capital divided Brussels in 10 regions with 10 vaccination centers, and in total 70 lines of vaccination. There, the hospital, the military hospital, occupied 10 lines of it. So we were the second one of Brussels. So that's a photo of the huge hospital. Then the vaccination center, as you can see, I will try. It was mandatory that there was a clearly in and a clearly out for the patients, and that was well done by the medical planners. They had also a waiting area, and for us as pharmacy, it was mandatory that the pharmacy was nearby the vaccination center. That was the case here in the military hospital. The space management in the vaccination center, there was a registration in of the patients. Then they had to get their vaccine, and there was also a registration out of the patients. What was our role in the pharmacy? It was controlling the towing process, and now, from now on, it was also the preparation of the ready-to-use syringes, and also the traceability. The goals of the vaccination center, I told it already, it was 10 lines with 20 persons a line an hour. So we had 200 persons an hour, so that will mean 200 vaccines an hour. And we opened at 8 o'clock in the morning. So all of that, we needed extra personnel for doing all the preparations and the logistic works above our routine work. Here are a little bit statistics. We worked with the 4 sorts of vaccines, so Pfizer, AstraZeneca, Moderna, Johnson & Johnson. And as you can see, we worked a lot with Pfizer, so I will tell you always about Pfizer. All the vaccines had other characteristics. So the storage was different, the conservation was different once they were towed. There was a dilution with Pfizer. The conservation of the syringes was different, and also the volume was different of the syringes. So that making it easy for the vaccination center when we worked with the 4 sorts of vaccines. Here is the flow of the Pfizer vaccines. So we get the orders from the Brussels capital, and they sent us our vials that we needed. We received them and transferred them at -80 degrees. Then we had to tow them and storage them in our cold room. We had to transfer them to our work area and verificate every vial that there was no damage. Then we prepared them in a laminar airflow that was with the goods manufacturing process. So we choose it for that because we make the vaccines in the pharmacy. After that, we labeled the vaccines, and we also filled in a report that we had a traceability. Then all the vaccines were packed in boxes and transferred to the center, where there was also a labeling or traceability. That's the last one here, right? Yes, here. So that was with lot number, with internal lot number for the pharmacy, and so there was a traceability from each vial to each patient. Here you can see in just in detail that a towing process took us once a day 30 minutes for 300 vials. And also when we transferred them to the pharmacy, once they were defrosted, we had also verified them of the integrity of the vials. So it was a huge work just to tow the vaccines. Here you can see how we prepared them. So the opening of the vaccination center was at 8 o'clock, and the pharmacists started at 6 o'clock in the morning to prepare the laminar airflow, to prepare the devices, and then to begin with the filling of the syringes. We had 10 lines, so we had 200 syringes an hour, and we calculated that each pharmacist or assistant could prepare 70 syringes an hour. So that will say that we needed 3 teams of pharmacists and assistants to do 210 syringes an hour. Here you can see then when... It's okay. Here you can see that the assistant or a pharmacist can prepare the devices when the first lot was prepared. Then they started the labeling of the syringes, the box packaging, the transport, and so we have done it for hours and hours in the pharmacy. And here is my conclusion. So I have set it in a SWOT analysis. I think that the strengths of our vaccination campaign was that we have prepared the syringes ready to use in the pharmacy. It was easy, it was secure, and it was a speed for the vaccination staff. We were also very flexible. We started very early, and we stopped only when the last patient was vaccinated in the vaccination center. So we had no many waste of vaccines. There was a great support between pharmacists and NCOs, and for me personally, it was a great enthusiasm and cohesion of the pharmacy, the vaccination staff, of all the other pharmacists that came by to help us in the pharmacy. So I'm very happy with that. Then the weakness that was for us that there were several deliveries per week to any time of the day. It was sometimes it was 6 in the morning, sometimes it was 6 in the afternoon. The supply was uncertainty, and the workload was very high in addition to our routine work. The threats were the mistakes with 4 sorts of vaccines. It could lead to mistakes, but we had a good traceability. It was a complex inventory tracking because we had several target groups. We had expats, we had diplomates, we had our Brussels population, and we had an endowment for each target group. So the inventory was very, very long and very severe to do it. The prescriptions were often not available, so that was also a massive amount of administrative work. But I think that we have also an opportunity, that is that we have a well-defined process for a 3rd dose that we're gonna start next week. So I thank you for your attention.
Thank you very much. And next will be the Lieutenant Colonel Sophie Salle, and she will show about the commitment of French Ministry of the Armed Force to vaccination planning. She is posted at the Central Direction of the French Military Health Service. Thank you, Sophie.
So, thank you for your nice introduction. General, sir, dear colleague, it's an honor for me to present the commitment of the French Ministry of the armed force to vaccinate its community and the French population. Appeared in December 2019, the SARS-CoV-2 took only 3 months to spread from China across. Oh. I will do with that. Sorry. So, appeared in December 2019, the SARS-CoV-2 took only 3 months to spread from China across the world and saturated health system. In front of the new threat, one of the solutions to limit the spread of the virus was to lock down. Moving past the shock, tools became gradually available to fight the pandemic. Then, less than 1 year after the identification of the virus, new vaccines were available in France. To help the return to the normal life, the national vaccination strategy has 2 main objectives. The first one was to reduce mortality and severe form casualty. The other was to protect health workers and healthcare systems. 3 principles have governed the vaccination campaign. First is a free of charge access. The second is an access on the willingness of the patient. And the third is the safety of this medical action. Because of gradual availability of doses, access to the vaccine was triggered, set on various criteria such as age, comorbidity, occupation, and life circumstances. Of course, as you can imagine, the plan was not really the same in reality. So, regarding the specificity, the Ministry of Defense proposed a specific and adapted strategy that was validated in January 21. The objective was, first, to protect the health of deployed men, especially when health support is limited or less available. Then, the second objective was to sustain the operational capacity by limiting impact of the COVID spreading in operation. The last objective was to participate to the national effort by vaccinating its population. For this, advanced procurement for priority operation was awarded, as well as allocation for vulnerable people. Mandatory vaccination was decided for special activity, and vaccination was recommended for all others. SSA was designated as a specific coordinator and actor for the anticipated operational vaccination. In other cases, the choice of the vaccinator was free. But all military people have to report the vaccination to the SSA. So before exposing some action of Ministry of Defense to the national vaccination, I will try to sum up the organization of the military vaccination campaign. First, SSA is an integrated military health system, including most of the medical skill. As soon as October 2020, a task force was dedicated to the vaccination. Led by the biological risk advisor of the director, coordinated by 2 executive officers, he has point of contact in each subdirection of the SSA. The role of this task force was to coordinate the campaign, propose medical advices to commander, and prepare discussion with public health actors to have vaccines. So the first step to vaccine is to define the medical strategy. Only one reference was used for more readability for the actor and to supply chain efficiency. Based on legal and scientific work, especially on variant responses, but also regarding operational constraint, supply chain capacity, and the national allocation for forecast, the Comirnaty type Pfizer was chosen for the military campaign. The second step was to choose the immunization schedule, and we describe a 3-week valency scheme, and only complete vaccinated people were allowed to move for the operational vaccination. A technical guide was communicated to operator, and the outline was proposed. Then, to vaccinate, we needed vaccines, so we had to be sure that demand of the armed force meets supply by the Ministry of Health. For operational vaccination, a close dialogue was required with the Joint Chief of Staff to define the high priority operation. Then, the aim was to define the adequate numbers of doses and cadence delivery to ask them to the Ministry of Health. Upon validation, regulatory text was published and vaccination chains opened to have a fully vaccinated people at the date of the departure. Operational vaccination was first open to a short list of operations, then in April to all operations, and in May to all missions overseas. In the same way, we have vaccine allocated for our vulnerable people in the ministry. And the vaccination was open to all the population in June. In July, regarding the new wave of contamination, our president introduced the health pass for a listed activity, and vaccination became mandatory for all health workers in the country in September. In the same time, the military mandatory vaccination was expanded to all incorporation, education, and training. But to vaccinate, we also need vaccination chains. The first one was for the aircraft door, and it was supplied by our hospital because the aircraft has to move in February 21, and the military chain was not already operational. That's why it was the hospital, the military hospital in Toulon, would do this vaccination. Then, in a proximity logic, the Direction of Armed Force Medicine, with its 200 medical office all over France, was designated to be the main actor of the military campaign. 45 sites opened in April to gradually increase to 130 in July. The organization paradigm shift in July, whereas at the beginning all doses was counted. Then in July, we have to promote vaccination to convince and decide people. Furthermore, the DMF also have to promote their offer in a context where, when other civilian center was open, we have concurrence. Overseas, no military medical office received vaccine, so the third partner, we had to make a partnership with local structure overseas. So then, to vaccinate, operators need to receive vaccine, and then we challenge our medical supply chains. The main constraints were the 5-day stability in refrigeration, and especially at the beginning of the vaccination campaign, the tap flow with Pfizer, which directly supplied our 2 medical pharmacy centers each week. Then, each medical office has to be supplied each week. For that, orders have to arrive on Wednesday to be prepared and shipped on Monday or Tuesday. To avoid losses during the rise in temperature during preparation, each plate received from Pfizer are reconditioned in smaller racks, custom manufacturing with our 3D printers. Hopefully, in May, stability to refrigerate increased to 1 month. This evolution has allowed us to space supply to medical office and mainly to send vaccine overseas where ultra freezers are not available. Then, since June, we can supply our prison forces and their family too, and deploy soldiers who sent in operation without vaccination because of a COVID history or a lack of delay to vaccinate them before departure. My last but not least focus will be on the reporting challenge of this campaign. The decision was made to only use our medical software Axon. The national system was not used to avoid a double entry data and for cybersecurity reasons. Hopefully, thanks to interdepartmental cooperation, our team were able to introduce in the vaccination certificate the national QR code and then the European Green Code that were needed for the health pass. But why did we use Axon? Since COVID vaccination is mandatory for numerous activities, report in Axon is essential to help physicians define medical fitness for duty. Furthermore, by characterizing the vaccination with vaccination pattern, so if it was an operational one because of a vulnerability, and to define the armed force belonging, this participate to the reporting to the armed force, since they were not allowed to do that because vaccination status is covered by medical confidentiality. But this action have a very big disadvantages. It's that it's not comprehensive, since it depends on the report of vaccination realized by other operators to the SSA. So, in July, regarding the strong difference between armed force immunization coverage and general population one, the aggregation of Axon data and national system of health data was performed, and thanks to that, now we have a robust indicator for coverage. In middle of September, we have almost 92% of armed force people that have begun a vaccination program, and 82 who completed it. Now, let me talk about the support of military of defense to the vaccination in the French population. On March the 25th of 2020, in the front of the military field hospital presented yesterday by Antoine, our president called the armed force to contribute to the interdepartmental commitment against the spread of COVID-19 pandemic. Resilience operation began. On the vaccination front, various actions were supported, such as reinforcement of the vaccination task force of the Ministry of Health by military logisticians, use of Air Force and Navy to support the supply chain, and we support vaccination center, as for example in New Caledonia last month. But the most important action was that in April, Pfizer vaccines availability increased sharply. Then, the capacity to administer them had to be improved. Consequently, the Health Ministry requested armed forces to support this vaccination and to all vaccination centers. Since they were under resilience operation, our mega center administration was led by regional commanders. Supported by a medical director from SSA, they were in charge to discuss with the regional public health system to have their vaccine allocation to aim the objective of 1,000 injections each day by center. This objective was reached by our ministry. But to preserve the SSA capacity, strongly impacted by 1 year of crisis, 2 types of centers were deployed. 3 military vaccination centers in which the medical staff was supplied by civilian people. 7 other mega centers were attached to our military hospital. The 8th SSA mega center was implemented in our military medical school and supplied by our military health students. 2 other points deserve to be highlighted. First, to increase injection capacity, injector and prescriptor panel were expanded by the law. For example, pharmacists and dentists were allowed to prescribe, and veterinary doctors and firemen allowed to inject. So, for that, a special formation was quickly made by SSA. The second point is, as military men, some military people and their family had to move abroad during summer. Regarding the date of national opening and the date of their departure, a no queuing access was implemented to our megacenter. In the context of interdepartmental cooperation, this procedure also profits to people of the Ministry of Foreign Affairs. In conclusion, even if vaccination campaign is not yet finished, main mission of Ministry of Defense was achieved. By conducting the early vaccination of priority operation, SSA accomplished its mission of operational medical support of armed forces. At the same time, Ministry of Defense reaffirmed its position in the resilience of the nation by supporting the national campaign, both by vaccinating its own population and by supporting the national public health system. Even if we still have lessons to learn from this crisis, 2 points can already be highlighted. The first one is, as an integrative health system, organization and competence of SSA strongly contribute to the agility and reactivity needed to control this unscheduled vaccination program during a major crisis. The second one is that this campaign vaccination confirmed the importance of medical advice to commanders by SSA, but also the importance of the civilo-military cooperation. Thank you for your attention.
Thank you. Okay, thank you, Sophie. Next speaker will be Coronel Ariñez, and she will expose the Spanish vaccination strategy and the paper plate by the Institute. Thank you.
Sirs, generals, ladies, gentlemen, colleagues, I'm very thankful for having the opportunity to address to all of you and present an overview of the military activities and actions related to support the Spanish vaccination campaign. This is the agenda, the topics I will follow. I will start presenting the Spanish COVID vaccination strategy. I will follow to briefly comment on the COVID vaccination coverages in Spain as of the day of before yesterday, 4th of October. The following topic will be military COVID vaccination strategy, together with the own system registry for vaccination called Sendala, which has allowed us to issue the COVID digital certificate. It has also been a tool to monitor and evaluate the vaccination, COVID vaccination in the armed forces. I will speak about some health promotion, which has been a paramount issue in trying to convince and inform people about the vaccination, our communication activities, and the other support to public health system. In the framework of the European Commission strategy, which was released on the 15th of October 2020, it was the basis to draw up the Spanish vaccination strategy, following the pillars and the principles of the European strategy related to acquisition of vaccines, principles of ethics for vaccination, and the way to contribute to the public and national vaccination systems. The vaccination strategy in Spain was released at the beginning of December 2020, and it was agreed in the Ministry of Health by the Commission of Public Health and the Interterritorial Council, where the health councils of the different autonomous communities are represented. In Spain, I have to comment that the health system is decentralized, except for the international health, and so that every health counselor has to agree in the Commission to apply or to follow the policy of the Ministry of Health. And the strategy, and this strategy, national strategy, takes and is written to be useful for the whole territory, so that all the autonomous regions are going to follow the same principles and prioritization of groups for vaccination. Also, it arranges the fundamental aspects related to logistics, distribution, and administration of the vaccines, and establishes the priority line for monitoring and evaluation of the vaccination campaign. After that, following the principles of the European strategy, what is our objective? To reduce morbidity and mortality in our Spanish population. The objectives were to vaccinate first the most vulnerable people, because they could develop severe symptoms, or those who might be at higher risk of contact with the virus. In a second step, it was to vaccinate those who were to preserve the functions, essential functions for society, such other professionals, and then people related to education, and so on. For the COVID vaccination strategy, it was established a technical working group at the Vaccine Committee, and was coordinated by Interterritorial Council of the National Health System. It has been an advantage for Spanish Ministry of Defense, because we have had several representatives in this technical working group. I know, sir, at the beginning, you were one of them representing the Ministry of Defense. There was a representative for the CIS, for the technical information, I will explain now. Another one for preventive medicine or public health, a different one for logistics, for the vaccines, and there was another one. Okay, so we could speak with the Ministry of Health directly. We were considered as one of another autonomous community. It has been, from my point of view, it has been an advantage to work always in line with the principles of the Ministry of Health. What's the situation about the vaccination coverages now in Spain, as of the day before yesterday? Most of the vaccines are Pfizer, and we have also administered Johnson, although it's not in the slide. Now we have distributed more than 75 million doses, administered 70 million doses, and fully vaccinated personnel, more than 36,500 million people in Spain are fully vaccinated. So that at least have received one dose, 79.5% of the Spanish population, and 77.4% have received the 2 doses. Well, 1 dose if it was Johnson. Compared to other vaccines in Spain, and with the controversy of the vaccine, of COVID vaccine, we consider it has to be improved, but the figures are not so bad. I'm sorry because here I had two texts, but I will explain which ones are. The vaccines we have used more are Pfizer, also in the armed forces. This is for older than 40 years. At least here, this column shows at least 1 dose. This depicts that the media for older than 40 years is 95% have received 1 dose, which is not bad. And this column here depicts the coverage for fully vaccinated personnel over 40, which is 93.9, which is even better. And last night, I took a look at the report of the 6th of October. And they showed in the report, in the Ministry of Health report, the coverage of people older than 12 years old. And divided by groups, from 12 to 19 years old, 1 doses have been received by 83%, and fully vaccinated from 12 to 19, 78.5, which I consider is quite good. There is a problem, or the interval of age, which has lower rates, is from 20 to 39, which is they have received 74. Fully vaccinated people are 74.5. And that's we will see later, because my colleagues who are coming later are going to show the results of vaccination in the armed forces. This is the interval 20 to 39, where most of the armed forces personnel can be included. And I can give good news. Our percentage is higher than 74 fully vaccinated. This slide depicts how many doses per 100 inhabitants in Spain as of September the 30th have been administered, which is not bad. This is the media of Spain. And we have some autonomous communities with 160 more, which is not bad. Compare this in this website, statistics had compared to other countries in Europe, and Spain is in a very good position. Of course, it has to be improved. What happened when the strategy of the Ministry of Health was released? That we knew in the armed forces, we had our population, military personnel has some certain characteristics, and the armed forces is mandatory, and the government has agreed that we had to maintain the people deployed abroad. We have to maintain people in operations. Therefore, the Surgeon General Office and the Institute of advised by the Institute of Preventive Medicine and the Directorate of different branches of the armed forces and the Operation Command, we elaborated a strategy for the armed forces with the aim of protecting the health of our soldiers, having the people, especially those who are going to deploy in good conditions, because we suspected from the beginning that the vaccine reduces the possibility to develop severe symptoms, and also to prepare our medical personnel to be ready to support national vaccination system in case we were required. Therefore, we were ready with this strategy. We were ready to support public health system, especially also because the Minister of Defense, Margarita Robles, stated in different forums that the armed forces were going to stand by the Spanish population, once again, to support within means and capabilities, especially in terms of supporting with logistics and vaccination personnel and vaccines. Therefore, as I have said, we prepared the strategy. First groups were to vaccine the physicians and nurses from the military medical academy, just in case, because they are, most of them, those who are have entered in the military world with the degree on nursing and medicine already studied at university, so they were able and legally they could be used or to vaccinate, to help and to vaccinate people. First line healthcare personnel in military hospitals, and also physicians and nurses from military units in order to support the civilian vaccination campaign. And we also had to strengthen and to adapt our vaccine own registry. The vaccination started on the 5th of January. The 3 wise men brought the first vaccines to the armed forces. So we had to prepare means and personnel. And how we did it? We did it with the Military Center of Pharmacy, which wrote procedures for stocking, sending, distributing the vaccines, and for units, and even in the Preventive Medicine Institute, there is a international vaccination center for us to require the vaccines we were going to administer. We also prepared personnel because minister ordered to have to prepare some mobile vaccination teams in case or should they be required to support national vaccination campaign. And we also prepared some education program. What we did, we knew that it was not so easy, and it was, this morning I was going to speak about uncertainty, but after Major Clay's, I will change the word because of, we were not so sure how to handle the vaccine, especially when you have to handle the dry eyes and you have to be equipped. And this, the Captain Colmenar, who will speak later, knows a lot about that. So we prepared a video to showing to our colleagues in military units how to prepare and how to handle the box, the big box and the small box, and the vaccines and the vials in order not to lose any doses. We also prepared together with the nursing department of the Surgeon General Office some infographies for our colleagues, and the vaccine requested procedure to have everything organized. And in the strategy, we reflected other priority groups apart from medical personnel: the military emergency unit, PCR analysis centers, as we knew yesterday in the Spanish Armed Forces, the veterinarian and the pharmacy have adapted their supplies to make PCR analysis. We also included alerted personnel to deploy abroad and other critical military staff who was considered that it was best option to have them vaccinated. We supported, military personnel supported the national health system vaccination, transport to different autonomous communities by road, by plane, wherever it was needed, our forces were there. And also the Military Center of Pharmacy. It has been a real challenge for them, as well as we have known from for the Belgium colleagues. It has, I can imagine, it is a huge challenge to prepare the boxes, to prepare the conditions to keep the chain of cold, the chain of custody, as we have already known from the Belgium, is the same because they are the same vaccines and the same conditions. And here, this map depicts the military pharmacy services in Spain. Doses have to be and still are to be distributed to even to the islands, wherever, Ceuta, Melilla, so many places, and it has been a real challenge. And I have forgotten to add a map a world map because they have also sent the vaccines to different areas of operations. So it is still a central hub for vaccine storage, supporting then during the vaccination campaign and still for the future, the storage of national vaccines. It contributes to the distribution of those vaccines, not only for military personnel, but also for civilian vaccination plan, and in cooperation with the Ministry of Health. I have to talk about our own registry system. We had a registry system for vaccines such as yellow fever, meningitis, smallpox, It is because of Balmis. I'm confused with Balmis. Not now. Okay, for the other vaccines, to go abroad. Typhoid fever and so on. Okay, cholera. Our registry system is called Zendala, so that every military personnel, we have a personal portal where we can see, we have access to see which are the vaccines we have received along our military life. Then we included the COVID vaccine and the numbers depending on the vaccine. So we adapted with our system, and this system, the Ministry of Health has been working with the autonomous communities to build another system, registry system, which is called RegVacu. This is a registry for vaccination, COVID vaccination, because every autonomous community has a registry, a vaccination registry. So the Ministry of Health has built a national vaccination registry, and it has been fed by the autonomous communities and also by the Ministry of Defense. But the Ministry of Defense, we have fed this database only because with data from the whole ministry, because we are centralized. So that nowadays, sorry. I went on there. No. We can, because of this close cooperation, Ministry of Defense has been able to issue the COVID certificate. And it can be applied for through the website of the Ministry of Health and the personal portal. I go back, sorry. Another action of the military vaccination campaign is to contribute to the national vaccine adverse reaction surveillance system. We have we feed also the national registry, but we also have a procedure for the armed forces to notify the reverse adverse reactions through our own channel. This is the data of national adverse reaction as of 16th of September. And we can see that most of the adverse reactions have been presented in women. We are following the data. This is the intranet of the Institute of, in military system. And this is the intranet of the Defense Preventive Medicine Institute, which has been updated because or during this pandemic. We have tried to give information, to facilitate information to all our colleagues in military units, not only medical personnel, but also those who want to have information, truthful information, reliable to take a look. And then we have been updating because here we have information for the notification of cases, the registry of vaccination, etc. Here is, in this institute, there is a department of protection and health promotion with a where we have created some folders with the information related to the vaccine, and they uploaded the information from the Ministry of Health. This is the, in the armed forces, we can sign up in the military units the vaccination certificate, and those are the infographics we have developed together with the nursing department of the Surgeon General Office. I'm not talking about that because my colleague will speak about that later. And also some information for our colleagues when we could only administer 3 vaccines, Pfizer, Moderna, and AstraZeneca, trying to make it clear because there were many doubts and we had many phone calls. Which one should I choose? It's not possible to choose because depending on the age, depending on the group of people indicated by the Ministry of Health, we couldn't choose which vaccine to administer or to receive, but people asked for some information. Therefore, we created that information. And there is inside also this department, there is a psychology section, and we have built some information, some infographics also for the beliefs of people against vaccination. The certificate, the COVID certificate is not mandatory, and the Minister of Defense has made it clear in different forums. It's not mandatory in Spain, either for entering or for applying for a job or getting a job, nor for getting into a restaurant, getting into a museum, a theater, or wherever. But since the health system is decentralized, there are some autonomous communities who have introduced rules to ask for that certificate. So in Spain, there have been some, and it depends on the autonomous region, and it depends on the court of the autonomous regions. I don't know if you have read that in Barcelona, they are going to start asking for the certificate from next week on. We will see what happens afterwards with the court, but there are some, however, there are some persons, there have been some initiatives, people who don't know, if they are not informed whether it's required to enter a museum or a bar or a restaurant, so they have decided to have the certificate vaccination at hand, just in case they were required. In this East Preventive Medicine Institute, there is also an epidemiology department with information and notification for cases and contact tracing. And we have been closely working with command operations. This slide comes from a presentation we did to the Minister of Defense in May. And in May, we were saying, Ma'am, this is the status of vaccination of people who are going abroad, who are deploying on operations. The blue color shows the vaccination, fully vaccinated, and the green one, people who had some kind of immunity because either they had passed the infection or because they had received only 1 dose. Ma'am, we need to vaccinate. It's important for us to vaccinate people who travel abroad. And then it was done. And we told her, among vaccinated personnel, there have been no severe cases to evacuate home with this data we had then. And then it was done. In summer, this is the figure from summer. Almost everybody is vaccinated. It was 2 months ago, 2 months or 3 months ago at the beginning of the summer. The yellow color or the orange color shows people who had only received 1 dose. Nowadays, 100% in every operation. And I have confirmed the data because the colonel, I have asked the colonel before showing to you these figures. And now what are we doing also in the epidemiology department? We are taking track of how many people are positive after being vaccinated. These are the data from 17th of September, either with 1 dose, 2 doses, depends on the vaccine. And we see that there are some people who are being infected again after vaccination. And these are the data from the 1st of October. We update every week. We update the data for the Surgeon General and for the minister. And we can see that figures are increasing. We are keeping track on that, and then we will follow what happens even with the national data from the Ministry of Health. Some other contributions that the armed forces, actions that have been done to support the national vaccination campaign. Here we have the Minister of Defense, Minister of Health, and here we have the Minister of Culture. They agreed that the armed forces were going to vaccinate Olympic and Paralympic athletes before heading to Tokyo, and it was done. Furthermore, the armed forces vaccinated the national team soccer before Euro 2020. Conclusions to my presentations is that support to national health system has made armed forces positively visible to society once again. Military professionals constantly stand by Spanish population, as the Minister of Defense ratified. Civilian and military collaboration requires full coordination. I have already said that having been embedded among health counselors as another autonomous region has been paramount to work in line with Ministry of Health. Military medical personnel have shown to be prepared to support the population once again. And this sentence, I've had sometimes I've spoken along this summer with the Surgeon General, and I've said, okay, sir, we have a lot of work, but it doesn't matter. This is professionally fascinating. And then I saw this sentence from Hans Sincer. Infectious disease is one of the few genuine adventures left in the world. We are experiencing that adventure. And on some occasions where we play one of the main characters. Thank you.
Thanks, Coronel. So now we change the perspective, and we will have the psychological perspective and educational aspects that will be carried out by Captain Leticia Escudero. Please.
Thank you. Good afternoon, and with your permission, I'm going to explain the health promotion activities developed at the Military Preventive Medicine Institute during this last year. Again, I'm going to explain the health promotion activities developed at the Military Preventive Medicine Institute during this last year. Here we have the agenda. I will briefly talk about the Institute, our functions, the vaccination recommendations, and some vaccination data in Spain, pandemic fatigue actions we have developed, and the promotion of vaccination. Our unit includes a multidisciplinary team of health professionals who carry out an holistic approach to public health problems. The Military Preventive Medicine Institute takes into account the biopsychosocial approach to health problems. As a fundamental part of this philosophy, the psychology section supports preventive health strategies. This section advises to the Health Promotion and Protection Service. It gives advice on health education, communication, and information. These are the main pillars that facilitate the implementation of our preventive campaigns. In fulfilling our functions during this pandemic, the Institute has carried out numerous actions to support the Spanish Armed Forces. The technical counseling and reports have facilitated the mission of the health personnel assigned to care posts. We also provide support for conducting COVID rapid test and vaccination of the personnel in the Ministry of Defense. Our main concerns when the vaccination campaign started in Spain were diverse. Will our troops understand the importance of getting vaccinated? Will they accept it easily? When we planned the health activities for the vaccination campaign, we realized people's attitudes were very important to achieve the objectives. We wanted to send a clear message. Vaccination is the best preventive measure to fight COVID disease. The Institute is in charge of advising on the normative production regarding vaccination in the armed forces, as my colonel said. It also develops technical instructions on public health and preventive medicine. The Institute's International Vaccination Center has taken up the challenge to be the first to administer the COVID-19 vaccine at the armed forces. Never before has the general population followed the technical development of a vaccine with such interest, and it has become a main topic in press and social media. In Spain, some studies have been carried out on perceptions and attitudes related to the acceptance of COVID vaccination. As a summary of the results obtained, it should be noted the CIS survey and the Cosmo Spain survey. According to the Sociological Research Institute, official data indicated at the end of 2020 that even being Spain a pro-vaccine country in general, the population trend changed in just 2 months, increasing the negative answers. This seemed to be due to the information about vaccines appearing in the media, which generated uncertainty and doubts among the population. The Cosmo study is an international survey of risk perception promoted by WHO, and in our country, it has been carried out by the Carlos III Health Institute. The objectives of the study were to monitor the population's knowledge about the COVID-19 epidemic, the risk perception, the preventive behaviors that could be promoted, and the population's trust in the responsible institution and in press. The information collected has helped to design health strategies and campaigns. When they asked about the intention to be vaccinated, a clear increase was observed throughout the different rounds, from July 2020 to July 2021, due to the availability of vaccines. Vaccination in Spain, as my colonel already said, began on December 2020. Our main goal has always been to improve adherence to public health recommendations, and vaccination is paramount. The Institute has also attended as a listener to the Pandemic Fatigue Working Group. Fatigue has been defined as a lack of motivation to follow recommended protective behaviors. It appears gradually over time and is affected by emotions, experiences, and perceptions, as well as by the sociocultural and legislative context. All WHO indications on public health communication strategies have been taken into account to prepare our health promotion and protection materials and activities. The cornerstones guiding our decisions were the identification of priority groups, understanding their motivations and barriers, applying learned lessons, and exploring new ways of communication. We search for the participation of all health sectors in the armed forces. Our job is to support and advise the personnel the medical personnel in the units. So we prepare a brief repository of specific materials for military academies and training centers, which, due to their special nature, were a particularly exposed group. There has been a lot of emphasis on the importance of including health education programs for cadets. Their training conditions, housing, and group activities could be risk situations to take into account. As I already said, the vaccination campaign against COVID-19 began in Spain on December 2020. Aware of the large number of fakes and wrong information emerging, we once again followed the WHO recommendations and their guidelines for communication strategies on vaccines. One of our first activities was a brief info describing the most common misconceptions among general population. This and the rest of our activities are distributed to the armed forces and uploaded to the ministry's intranet for general access. Previously, in the month of October, we did not forget the annual flu campaign. In this health situation, it was more important than ever that our personnel were protected. From a psychological point of view, we know there are several reasons that lead people to reject vaccination. Fear of side effects, distrust in the safety of the vaccine, or even a lack of social responsibility are some of them. The most influential factor for an adult to decide to be immunized is the recommendation of their doctor, as some surveys show. Following this indicator, we focus our next section on the military nursing staff, which in the case of the Spanish Armed Forces is usually the most direct image the soldiers have. The military nurse is responsible for the vaccination process in our units. A personal letter signed by the Institute's director was sent to all of them, transmitting the importance of military nurses in this process. And we reinforced this action with a video distributed through the intranet. For us, promoting health actions is a challenge. As psychologists, I know changing people's habits or health behaviors is a very difficult task. Due to the importance of reaching all personnel in the national territory and area of operations, we are exploring new forms of creative communication, such as social networks. Our goal is to give a response to news and needs that affect our colleagues' health in Spain and abroad. I'd like to conclude with the estimated percentage of vaccination coverage. We have collected it through the medical headquarters of the armies. This is a general approach to the vaccination situation of Spanish Armed Forces. It shows that the acceptance of the vaccine is quite high, always exceeding 80%. We hope the Preventive Medicine Institute actions have been useful to improve the vaccination coverage on our colleagues. Thank you very much.
Thank you, Leticia. And now we will close the round of lectures with Captain Gemma Colmenar. She's nurse, so we will have a different approach. Before she starts, I have two news, one bad and one good. The bad is that after her lecture, we will not have coffee break and not coffee. The good one is that we will start immediately the discussion because the bus is leaving at 6 o'clock in order you will get some time to enjoy the city. So please, Gemma.
Sir Colonel, Sir General, with your permission. Good afternoon, ladies and gentlemen. First of all, I would like to thank my bosses for the trust that they have placed in me to impart this conference. Secondly, I'm going to try to pronounce the best as possible the English language. When the military nurses face vaccination of our military personnel, we follow a specific instruction for the Spanish Armed Forces on vaccinations, the one that marks the protocol of action. The current instruction includes what is indicated in a set of standards which enables military nurses properly accredited to prescribe and administer vaccines to achieve the following objectives. A basic module for a military personnel in national territory. A specific module for military personnel who will travel to the area of operations. And finally, vaccines that are part of vaccination campaigns, for example, how it has been and is being the COVID-19 in our days. Currently, 740 military nurses are accredited to perform this function, or which is the same. The total scale of nursing officers belonging to the military health corps nursing is enabled for it. Within the Ministry of Defense, a vaccination strategy was carried out following the guidelines of the national plan published by the Ministry of Health and its mandatory updates. The aforementioned strategy was aimed at vaccinating military and civilian personnel belonging to the Defense Ministry, following the priorities of the following established groups. Initially, health personnel and personnel to be deployed to the area of operations, and later the rest of the staff. Finally, the Defense Ministry took over the vaccination of other personnel, as elite athletes, Olympic competitor, a Spanish national football team, and personal link to the Spanish Armed Forces. In the first moments, the vaccines provided to the Spanish Armed Forces that were distributed by the Military Defense Pharmacy Center were Pfizer and AstraZeneca, being supplied later Moderna and Janssen. The selection of the type of vaccine administered, it has been made according to the stocks at all times within the Ministry of Defense, and in turn, depending on the age of the patient to the priority group to which belonged, following always the indication of the strategy established by the competent Spanish authorities, and of course, the indicated in the data sheets of each of the vaccines. If when performing the patient anamnesis, any problem was detected with indicated vaccines, the change in the type of vaccine and the medical evaluation were evaluated. Providing below the patient, besides contemplation a new appointment for a medical evaluation, the administration of another type of vaccine, or even the referral of the patient to the allergy service, or any other specialist what might be required. The Institute for Preventive Defense Medicine, in addition to participating in the vaccination campaign, it has been the reference point through the campaign so that health personnel, both doctors and nurses, could solve their doubts and make inquiries through phone, web, and email. It also treats patients referred from units that require special assessment before performing vaccination. At this stage, the military nurse proceeds to conduct an interview with the patient to gather information about allergies, pathologies, taking drugs, vaccines in the previous 7 days, contact with COVID patients, whether the disease has passed or not, the gestational situation for women, etc. Depending on the patient's responses and current criteria enforced at time of vaccination, the indication and validation is carried out. All this information is reflected in the pre-vaccination questionnaire of the Zendala registration system, which we will deal with later. As I have mentioned at the beginning of the presentation, the prescription of the vaccines by military nurses is endorsed by Royal Decree 954 from 2015 of October the 23, regulating the indication of use and authorization of the dispensing of medicines and medical devices for human use by nurses. Subsequently, there was a modification to this Royal Decree, Royal Decree 1302 from 2018 of October the 22nd, amending it the Royal Decree 954 from 2015 of October the 23, regulating the indication of use and authorization of the dispensing of medicines and medical devices for human use by nurses. A year later, it was regulated for military nurse in the Order PCI 581 of May the 24th, regulating the indication of use and authorization of the dispensing of medicines and medical devices for human use by nurses of the Spanish Armed Forces, and the Technical Instruction 221, February the 5th, 2021, of the General Defense Health Inspection on vaccination in the Spanish Armed Forces. This has allowed military nurses to face a mass vaccination campaign unprecedented in history. On the one hand, administering the vaccines prescribed by medicine, and by the other hand, and simultaneously, to have ability to prescribe themselves the vaccines that they will administer later. Thanks to the tools now available by nurses, which enables the indication and administration of vaccines without the essential presence of a medical officer in the barrack. With this fact, it has been possible to make much faster progress in the vaccination coverage of Ministry of Defense staff, considering that in many of these units and SIPs, they only have military nurses. At the bottom of this graph, you can see the military doctor and nurses assigned by Spanish Armed Forces. In this graphic is not included the staff assigned to units belonging to the General Health Inspection and another of the Central Defense. Once the above procedures have been performed, the nurse responsible for vaccination also assumes the health information activities, providing the patient in an understandable way with information about the adverse effects of the vaccine, differentiating those normal effects from those that aren't, and giving the necessary advice for each case. This has been one of the steps that patients have appreciated more and for which they have sent their gratitude, especially in the early moments where information through the media was very confused and ambiguous. Many people have doubts about the vaccine administration, the type of vaccine they were going to receive, if it was the good or bad vaccine, yes or not it was true, what they had heard on media or networks, or they had read in an article, or a friend told them, etc., etc. This was magnificent when the Ministry of Health recommended completing the vaccination schedule of the first doses of AstraZeneca with Pfizer, although it allowed to continue administering AstraZeneca for people who wanted to. At this point, the patient demanded a lot of information to be able to choose the vaccine with which they wanted to complete their vaccination schedule. They were provided with information that the ministry had published with the advantages and disadvantages of each of the options, solving all their doubts so that they could make the most appropriate decision according to their ideas and needs. The close relationship with the patient is one of the fundamental pillars in the nursing profession. Within the armed force, we, the military nurses, don't forget it, as long as it stays the discipline and hard eye in our field. For this reason, although this step could slow down the vaccination process, we have dedicated the necessary time so that patients could dispel all their fears and decrease the degree of anxiety in any of them. Once the patient has received the information and has the opportunity to ask the necessary question about it, we go to the next step, which is the delivery of the informed consent, that thanks to all this information is not only a document to be signed, but what really gives meaning to its name. In the vaccination strategy, it is authority by means of a verbal informed consent by the patient to receive the corresponding vaccine, information by the nurse in observation section of the Zendala system records. Nevertheless, the Institute of Preventive Defense Medicine published on its website a written model of informed consent. That informed consent collects all the information about the vaccine and its adverse effect, documents signed by the vaccine prescriber and the patient, confirming his authorization to receive the vaccine after being informed. This document was very well received by the health personnel in military units in the different armed forces barracks, given that one copy was stored in the infirmary and the other was provided to the patient. To facilitate the administration of the vaccine and other aspects, such as receiving vaccine, reconstitution, storage, required material, an explanatory video for the first vaccine received, Pfizer, was uploaded to the web. Subsequently, the General Defense Health Inspection, together Nursing Dissemination Group and Institute of Preventive Defense Medicine, make an infographic for each type of vaccine also available on the web, within reach of all health users with clear and simple information. Infographic that serve as a poster in the consultation, especially in the first moments, to avoid any type of mistake in administration. After the patient temperature is taken, the vaccine is administered. To arrive at this event long awaited by patients, previously, the military nurses had to face an overload of management and logistics work in order to provide quality care, and so that is not waste a single dose of vaccines against COVID-19. Tasks such as receiving vaccines in dry ice packaging that require special and careful handling, that thawing of this is reconstitution with the special nuances of each type of vaccine, without ever forgetting or stopping controlling the maximum times and the temperature at which each vaccine may be subject. Perform patient groups multiple doses of vials. Remember that each type of vaccine has different number of doses. Organize consultation to keep track of available vials. Vial need to request expiration dates, day and time, patient with second pen these doses, dates on which these doses correspond to them, count of doses administered per day, distinguishing first doses from second, complete vaccination schedule before the military deployed, the area of operation without interfering with their specific vaccination schedule. All previous is a logistical challenge for which the military are trained, and undoubtedly an activity that military nursing exercise in its day-to-day work. All this data are recorded in the computerized vaccination system of the armed forces called Zendala. This name is in tribute to Isabel Zendal, the nurse who accompanied Francisco Javier Balmis on his trip to take the smallpox vaccine. The World Health Organization considers her the first nurse in history on an international mission. All vaccination data record in this system are accessible to both doctors and military nurses in a military unit in our country. In addition, the vaccine is also recorded on the patient vaccination card. Registration in the Zendala system subsequently allows each user to obtain the International Digital Certificate of the European Union through their personal portal with the military intranet, or that healthcare personnel can provide it to them. In turn, the Ministry of Health launches the single registration system for monitoring COVID vaccination, while the autonomous communities and the Ministry of Defense report the vaccination data. These data are added daily from Zendala system. Next, I'm going to show you that data about the COVID vaccination campaign from the January the 5th to September the 12th, 2021. Administered 170,978 doses of vaccines. Although Zendala system has registered a greater number of vaccines belonging to the doses that had been administered outside the Ministry of Defense. A total of 6,257 personnel with one dose and 85,506 personnel with the complete schedule. By type of vaccines, AstraZeneca has been the most administered vaccine. In the early moments, when AstraZeneca was not limited, those over 60 years of age, it is the vaccine that was most administered to our staff. Subsequently, the second dose was given to choose whether to continue with AstraZeneca or prefer Pfizer. Many of them decided to complete the vaccine with the same one they had started. However, Janssen has been the least administered vaccine because it was given when a large part of the staff was vaccinated and by the criteria, staff over 40 who had not passed COVID. From here, the data are extracted from Zendala. They correspond to both the vaccine administered by defense and those that the communities have administered to our staff, and have subsequently being registered in the Tendala system. People vaccinated by armies, Army is the largest, and therefore the one that has administered the most vaccines. The age criterion highlights the range between 31 and 40 years old. And these are the doses administered to elite athletes, Spanish Football Federation, and Olympics and Paralympics athletes, and another personnel. Once vaccinated, the patient is asked to remain in the waiting room for about 15 minutes under the supervision of nurses for the control of possible adverse effects. When the legislation was updated to allow nursing to prescribe, the General Defense Health Inspection formed a permanent commission for development of the validation and dissemination of protocols and clinical practice guidelines and nursing care guides in the armed forces. Among them, they published a protocol for anaphylaxis that would serve as support in this situation and legal support. As in the rest of vaccine administration, to perform an adequate surveillance drug, adverse reactions of the vaccines are reported in the Tendala, and they refer to the General Sub-Inspection of Pharmaceutical Support and Management, although during COVID vaccination campaign, the adverse reactions has also been notified on the website of the Ministry of Health. From January the 5th to September the 12th, 2021, 1,606 adverse reactions have been reported. The Vaccination Act of a campaign in which health personnel from all over the world are dedicated with effort, dedication, and delivery, where nursing has been the cornerstone for the vaccine to reach the majority of the population in record time. Nursing commitment to vaccines has always been total, an activity linked to our profession to promote collective health by enhancing individual health. Military nurses have followed the same line within their forces: vaccinate all your staff as soon as possible, relentlessly in endless day. But with the conviction that we are fulfilling one of the most satisfactory missions of which we can undoubtedly be proud, because this has been transmitted to us by our patients to thank us, and they encourage us to continue in the most critical moments. Because it is difficult to lose a battle when working as a team, efforts are combined and rowed in the same direction, and we, the military nurses, are clear about it. Thank you very much for your attention.
Thanks, Emma. So now we have half an hour of, I hope, participatory discussion. So who wants to start? If you have any questions.
No, just a question of bureaucratic nature. In case that military personnel complete the vaccination program abroad due to its assignment abroad, or in case that it has the one dose abroad and one dose back in homeland, is there an ability to record this data to the relevant electronic platform, e.g. Centala, and thus issue the EU digital certificate?
Yes, it's possible. It has two ways to register. Either because the person deploys to a detachment. No. There are two ways to make it possible, because if the military personnel deploy to a detachment where there is Spanish nurses or doctors, they can upload, they can transfer that inside or when they come back. And then if some military personnel deployed to a detachment where there are no Spanish medical personnel,
they can transfer the vaccines afterwards when they return home in their barracks, their unit.
Yes, my question was about those people who are being vaccinated by third party, for example, from NATO, from SAFE, or from the Belgian government.
Yes.
In this case, since every dose of the single batch is matched to a certain individual, how this is there possibility for the system to admit this batch and have the EU certificate issue?
It's possible because we have that problem in Romania where they were deployed, and people from there, the company that was there, they send us to the direction of sanitary. For example, in the Air Force, that it was people from this army deployed there, and we, from the direction, translate to the computer, and they got even, and we had problem with people in the Arabian countries, and they sent from Qatar, and no problem, they got the certification.
But Carmen, if I'm not wrong, it was for the vaccines approved by the European Union. What happened?
With Qatar, even the same.
Yes?
Yes.
Yes, thank you. First of all, I want to congratulate you all that have been presenting the results of the Spanish vaccination program. I'm really impressed by all the work that you did and the great success that you made. So congratulations. Just for my understanding, I have only one question. I understood that the military personnel was all vaccinated in the military vaccination program. Was there no Spanish soldier or sailor vaccinated in civilian centers then? And if yes, how did you manage that?
At the beginning, it was only because of the availability of vaccines, because of shortage of vaccines, people were only vaccinated in the armed forces. But gradually, as more vaccines were available out in the civilian, in the national program, some people could be vaccinated before in their primary attention center in vaccination, because when the government approved the mass vaccination and for different group of ages, many people it was easier for them, it was quicker for them to be vaccinated outside the military ambience. Therefore, they were vaccinated and they did the same. They took the certificate either by the Ministry of Health or they gave their certificate to the military unit, and then it was transcribed into our system. And they could also. So I hope not many people have been vaccinated 3 or 4 times because they have not said anything. But people, and it was mandatory. Mandatory vaccination is not mandatory in Spain. But, however, people who had received the first doses within the armed forces, it was recommended that they receive the second doses within our ambience. But some cases, I don't know, maybe they need it, but most of them.
Yes, thanks for the presentations. It is amazing how similar all these things are in the different countries. From the scarce resource to the superfluous amount of vaccination. And we have to, we faced an perhaps unknown problem for you is data protection. So we had a big issue if somebody went to the civilian vaccination center and in the beginning we endorsed it and said, take what you can get. And then they went to the civilian and so on. And if they don't report back, nobody will know that they are vaccinated. That was we don't have this kind of central vaccination register, And our legal advisor said that it is only if you have a mandatory vaccination, then you are able to ask the people whether they are vaccinated or not. And that is amazing for military. So that is German reality. And so we are always fighting with data protection and so on. And the company commander has not the right to ask whether his people are vaccinated or not. And so exactly in the Bundeswehr, we don't know how many soldiers have been vaccinated until now. That is nearly a joke. Yeah.
Okay, in Spain, it's true that it's not mandatory, okay? But we had some problems with people that didn't want to be vaccinated. At least in the Air Force, where I post, we got last month, an operational requirement from the Chief of Staff in order that if you are not vaccinated, you are not going for an operation. So we had the problem that you have. So some people, not a lot, but some people went into the civilian in order to get vaccination. They didn't came to the Air Force with the certification, so, okay, I'm not going to abroad. Okay, that can happen. But because that problem we have, you could say strange, but almost in the most young people, in the youngest people. Okay, so Lithuanians leaving the academy, they didn't want to get vaccinated. Okay, I think it's not a good idea to start your military career in that way. So it's up to them. So because of the general staff, they say, if you didn't get vaccinated, you are not going abroad. So if you are starting in this way, okay, you can, but be sure you will never be promoted. That's an option. Sorry.
We also have an advantage because vaccine hesitancy in Spain is not very frequent, and anti-vaccine groups are not very popular, still not very popular in Spain, so we may have some cases of people who have not declared their vaccination, but there is always a case.
We have 20% of people who don't want to get 20%.
I think we had 2% in military academies at the end of the last course, in June. But there is also one reason, because they are in June, they finish in July, and they want to go on holidays, and they have exams, they have some practice to fulfill, and they know that with some vaccines, some relatives or some friends have been a little bit dizzy or whatever, so they were afraid they may not finish their education, and they thought, okay, I will get vaccinated in summer or afterwards, but I want to finish.
Real reasons.
Yes.
Thank you. Just for journal scopes, we got the same problem in Belgium. Recently it changed because the employer has the right to know the vaccination rate, and defense is recognized as one of the, but only via the occupational medicine, and the director of the doctor responsible for the occupational medicine has the right to know exactly which is the percentage of vaccinated within one company or one service of the federal state. But we will face a problem in the next future. I don't speak about the third doses, but within a couple of weeks, we will reach 95% of vaccinated. If you had a couple of percentage due to COVID disease patient who had COVID, were not yet vaccinated, which are not mentioned in our vaccination status. What do we do with the 5 reluctant percentage of people within our armed forces? And that will be till the day we have the obligation or the right to oblige the military to be vaccinated, as the US did in a couple of weeks ago. What do we do with the non-vaccinated people within the armed forces? It's an open question. I do not have any answer, but we have to think about that. And my last question for the psychologist: could you help us to convince this 5%? Thank you.
Okay, thank you very much for interesting and enormous presentations. I have a question to you, Carmen. When I remember right, there was a slide in your presentation about breakthrough infections in the vaccinated soldiers, right? Did you check via sequencing which variant or type of virus was responsible for these breakthrough infections? Or are you planning to do so?
In some of the outbreaks, in some, we have the identification because we know that they were in an atmosphere where the Delta, most of them have been Delta. Am I right, Helga? This is my colleague who is an epidemiologist and is taking care of all this information firsthand. Most of them were with Delta variant. In the armed forces, we cannot identify the species, but we have, when there is a need, we have contact with the different hospitals who have this technique, so there's no problem. It's as if we could also do it. Some of the cases are not identified, the outbreak and the variant is not identified. Even in area of operations, we have had some people, but it depends if the contingent we are deploying with has this technique or not. Sometimes, I have shown the figures of people who have been infected again, but all of them are small symptoms, light symptoms. Maybe because of that they didn't come to hospital and then we didn't identify or we didn't go so deep in the study. I have a question for different countries. Because we have had, the situation of being mandatory, the vaccination, since it's not mandatory in Spain, we have had some discussions about military academies, where the living conditions is in a very close environment. If there are some people who don't want to get vaccinated. The only actions, the only activities we have been able to produce is to give information and to try to convince them to get vaccinated. Is any of the countries has developed a creative idea to improve this situation? Maybe we can share it and we can put in practice and put it afterwards in common.
I will be more clear by saying what do we do with the anti-vax? Do we have it? That's the question. Do we dare to throw them out?
We can. Is it approved by law, in court? Here it's not.
It's a question.
Yeah. We had the same conversations.
So we try to have this mandatory vaccination due to our election and our commitment from our chancellor that there won't be a mandatory vaccination. So it was processed in the ministry, but was not decided. Yeah? So we have a mandatory vaccination for everybody who is going to a mission. That is, and this is very effective. After this decision, we have non-infection abroad. That is, it works. Mandatory vaccinated. Then we have a program that we have 5 or 6 vaccinations that are mandatory. So we call it the basic vaccination scheme for our soldiers. So that is tetanus, cholera, hepatitis, and so on, and influenza. So, and if you don't do this vaccination, you will have disciplinary action. You will get a fine and so on. And in the end, it is written down that you refuse to be vaccinated, and if you get ill, you have to bear the consequences. That is one way to do this. I don't know how, in the end, it will be put through, but that is we have disciplinary action if you don't go to the doctor and get a vaccination. But we tried to add COVID to this basic program, but as I said, until now we have failed. So it is for me. I cannot understand that this vaccination is so something special that we have problems to say, okay, it's mandatory. We have measles. Yeah, it's mandatory for every teacher to have a vaccination against measles since last year. No problem. But COVID, that is a problem. That is something psychological, I think. Yeah.
Thank you, sir.
Just to add some thoughts from Greece about mandatory and compulsory vaccination. First of all, during my previous question, I forgot. It's my mistake to thanks for the presentations. And in Greece, it's not mandatory. It's mandatory only for the medics, for the medical personnel. And if a medical personnel does not complete the vaccination program, then he is expelled from work. Not fired, but expelled. Only for the period of time that he is not completed the vaccination program. On the other hand, we have the problem of asking who is vaccinated, because it's not mandatory and he is not. He has the right not to answer, but we put mandatory vaccination for the position, not for the people. That means, in order to participate to the operation, to the work of an operation center, he should be vaccinated. Otherwise, he has to follow the limitations regarding the people who are in a close area. Even for the operations, the compulsory of vaccinations refers to the position, only to the position, not to the man. If he is not vaccinated, he cannot participate to the exercise or to the mission. In last month, we made a survey about mandatory vaccination among NATO countries, and we saw that France and US have mandatory vaccination of the personnel. Greece, Hungary, and I don't remember the other nation has mandatory vaccination for the medical personnel. I don't know whether we can do it mandatory due to legal, to human rights and legal limitations.
In France, we have mandatory vaccination, but we have 2 types of mandatory. It's one about your medical fitness to serve, and the other one only for health worker. It's in the law, and so there you have to, and if you do not, you are removed from your post. And after we still have discussion because effectively it's very hard to apply. But I think this mandatory vaccination, the first aim of this mandatory vaccination was to convince people to be vaccinated. But it's just my opinion.
Thank you. No more? I have one just for Belgian pharmacists. It's because I have a bias, and I'm a microbiologist, so it's more technical question. Why did you decide to distribute the vaccine in the syringes in the laminar flow? Because it's only can do it on a hospital. You can not do it that in other. So it's just to be more complicated and just more difficult.
It was just to follow the GMP rules, and because we did it in the pharmacy, we had to. Yes, we had a cabin, so we did it therein, and it was good. We had no bacterial infections. We had a larger time to distribute the vaccine, so that was an opportunity to us to do it in a laminar airflow. So it was better for us. I will say it. But complex.
The thanks in Spain is that we didn't know that, because if not, our politics will decide another thing. So now I think that if you don't have another question, no? Carmen, the Coronel Ariñez will be resume the other questions?
No, because Fran also has to make a summary of the morning sessions.
Oh, okay.
Both of us. So
Okay, so please, Lieutenant Colonel Daza, you start. Small resume. So you will go home, the hotels, and you could enjoy the city. So Lieutenant Colonel Daza will present the resume of this morning, no?
Yeah.
Okay. Thanks.
So good evening, everybody. I'll try to be very quick because everybody is dreaming for their beer and their dinner. Okay, so am I. So I'm going to resume very quickly both panels of this morning. Yeah. The first panel, the first lecture was the choice of unpreparedness was an eye-opener. The idea, the hypothesis is that nations choose to be unprepared and justify their unpreparedness with a narrative of uncertainty. But there were ample warnings before that, like SARS, MERS, various specialists stated the warnings, but the experience for past centuries should have been used as a reliable indicator. And we are still in the wrong. We are still making moral medical choices. The example was put of the VJTF and the missions in Sahel. They are consistently lacking medical assets, and we don't remediate it. There's roll to afloat were mentioned, casualty staging units, and the strativac. They're identified as lacks in the mission areas, but not corrected. So the great eye-opening is, can we really speak of operational challenges and uncertainty when they are the logical conclusion of our own choices? And the COVID-19 has shown that total unpreparedness is a conscious choice that bears consequences. Today, uncertainty cannot justify unpreparedness. The second was the contribution of military medical services, the Greek military, medical military service to the pandemics in Greece. The Hellenic military medical services is an integral part of the country's health system, and they assisted the national response, providing personnel, general staff, sanitary staff, and medical experts, military hospital infrastructure and equipment, beds, both ICU and ward beds, mobile medical unit for emergencies. They helped with the creation of medical stockpiles, support to the mass vaccination programs, including logistics and staffing, assisted in implementation of the epidemiological surveillance program, and they contributed to the senior leader engagement across established government committees, especially with Infection Control Committee. The most important key lessons and specific considerations are the vulnerability of our society, our world, to a biological threat, the need of early attuned and generally compliable guidelines within NATO and European Union in order to avoid duplication, the value of effective cooperation between all stakeholders, the need for telehealth development and interoperability, and the need to adapt with the science uncertainty. The third presentation was the assistance provided by the Bundeswehr. Roughly 8,000 requests for assistance by the German federal, regional, and local authorities were presented to the Bundeswehr Joint Medical Service. 25% of them were specifically medical focus. The Bundeswehr contributed in several areas, like engaging with non-military medical actors, enhance local medical capabilities, provide command and control capabilities, provide medical support logistics to allies and friends. Specifically, they mentioned the international assistance in Portugal and India, collect data, share scientific data and results, and promote translation of science to real-world capabilities. The main conclusion is crisis cannot be resolved in isolation, and the uninterrupted permanent support that is provided by the Bundeswehr by a body of personnel that is limited in number has caused problems in the Bundeswehr, like they couldn't take full. They couldn't deal with the main effort, which is the original task, which is the support to operations, and it has produced displacement effects. The fourth presentation was from our Spanish colleague, the COVID prevention measures and operations, how the Spaniards reacted. So it was mentioned that it was one of the largest crises in the world since World War II. And in order to mitigate this new health risk, it was necessary to establish specific health protection plans with several objectives, like early detection for possible cases, reduce the risk of infection, ensuring the health and operability of the force, prevent importation of cases, and prevent the export of cases to deploying nations for nation military personnel. The measure was established with 3 goals, which was prevent, detect, and respond. And they included establishment of quarantines and performing diagnostic tests to rule out the presence of a disease, both pre-deployment and post-deployment. The deployment of contingency plans in the detachment made it possible to control outbreaks in the detachments. So the major conclusion is that the incident rate of COVID-19 in operation in Spain, according to the data evaluated, was 4%, and it can be concluded that the measures implemented have made it possible to control both the occurrence and outbreaks and impacts on operations. The fifth presentation was the lesson learned of CSDP operation submission. It was presented that there are actually 17 missions, 6 military and 11 civilians, and there was a calendar of a lesson process, like lessons identified in August 2020, the implementation plan of EEAS in November 20, and the progress report just last July 25. The main findings were they detected a lack of resilience both in the field of duty of care and in the field of military and civil cooperation and coordination. In the duty of care, the lack was they identified lacking of flexibility of medical contractor capabilities and solutions in the field, and that they should only serve temporarily as a last resort option. And the proper supply of medical equipment and testing capability, including the COVID-19 testing kits, the rapid tests, and the PPE, the personal protective equipment, and the increase of stocks and basic medical supplies, treatments, and isolation transport means. And for the civil military cooperation and coordination, they function well on a case-by-case basis, including deployment of personnel as well as supply of medical assets, and the backing of enhanced and flexible civil and military cooperations. The conclusions were that lessons process contributed relevantly to improve the capability of these CDP missions. Most of the issues were captured in the process, and some actions have been closed, and some work is ongoing, closely monitored. The second session were 6 presentations. The first one, CIMIC, Innovation in Crisis. It was presented the dilemma between bureaucracy and the modular approach. They presented a modular approach based on a toolbox consisting of nine tools: command, control, and communications, evaluation, resource and development, epidemiology, patient care, laboratory testing, type and sequences, risk, crisis communication, outcome, administrative execution, health promotion, and vaccination. The Medical Intelligence and Information, MI2 unit of the Bundeswehr Medical Service, contributed with several areas of work, like evaluate the outbreak management of different public health agencies in southern Germany, set and implement a corona early warning system based on wastewater monitoring, optimize the Bundeswehr Medical Service Headquarters Management Dashboard, and start pilot studies for an early warning system based on wastewater monitoring in domestic military bases as well as abroad in Mali deployment. And the conclusions were the real crisis, what we need to tackle is a five-item approach: technical level, the triangle of interdependency, leadership, public health and digitization, administration, bureaucracy versus crisis management, strategic level, global health diplomacy, and sociopolitical perspective. The civil-military cooperations lead to a win-win situation for all participant entities as we are learning from each other along as we are open to cooperate and innovate in crisis. The second and third presentations were more detailed in the Slovak army. They presented the paper and how they deal with the stresses and the challenges that presented the COVID. The first of them was the use of Slovak mobile field hospital. They described what was the implication during the first and the second wave. They mentioned several operations: Carousel, Umbrella, Return, and Sekplinski, with testing of Roma settlements, security, establishing quarantine facilities. And in the second wave, the most important of them was the common responsibility, common rampart, and continuity. And the third presentation was specifically decided when they did a mass testing for the Slovak population. They tested like 3.5 million people. The fourth presentation was the development of COVID-19 testing capacity in the Belgian army. The outbreak raised the need to develop a new testing capacity in Belgium to monitor the pandemic and to keep the spread of the virus to a minimum. The Belgian government chose to support the development of PCR-based techniques, and they needed it for the pre-deployment testing to avoid the restriction on test indication imposed by Belgian authorities and the need for them in theater testing. This initiative avoided the clogging of the civilian testing capacity and allowed the military hospital to screen every admitted patient as well as military personnel prior to the deployment mission. They developed two different PCR-based methods that were implemented. One provided a high sample throughput, mostly for pre-deployment use, while the other one, a small fully automated, the Gene Expert, were easily deployable in the field, on ships, and on operation theaters. This overall strategy, together with vaccination, enabled Belgian defense to resume some of their activities normally. The fifth presentation was the investigation of a COVID-19 cluster in France. The study presents the methods and results of the investigation into a COVID outbreak in a professional community. They report the effective use of targeted testing according to pre-test probability, specifically prioritizing symptomatic COVID-19 diagnosis and contrast tracing. The approach was systematic screening versus contrast tracing. So the point decisive was the prevalence of the illness inside a cluster where there's a high prevalence, a high probability to have pre-symptomatic cases. A systematic screening saves time compared to contact tracing, where when there's a low prevalence, mass testing in a low prevalence population may lead to several issues, like possibility of false negative and false positive, and saturation of biological capabilities, and then they prefer active case finding and contact tracing. The contact tracings with two main objectives: identify the cases to take care and isolate, identify the infected to quarantine them and stop the chains of transmission. And it has to be forward and backward. So the approach was test, trace, isolate, test, more efficient targeted testing based on pre-test probability, based on context, exposure, and clinic. And the last presentation was a chemical intoxicated trauma patient was the approach by our German colleague, where traumatic injured patient exposed to chemical warfare agents or related compounds requires immediate trauma therapy even before decontamination, otherwise survival is unlikely. These patients need to be exposed to treat, but with reasonable precautions to minimize the further addition of additional exposure. And they presented here with formation, which is the flight tube, forward light element for decontamination of patients and personnel. It's a new concept to handle chemical intoxicated trauma patients in addition to personnel and to some extent personal equipment. It's tailored to mission, and it's managed either by the CBRN specialist or by the senior EMT paramedic with one common aim, saving the life of the chemically intoxicated trauma patients. The main idea is treat first what kills first. And that's all on my side, ladies and gentlemen.
Bus will be waiting for you, so don't worry. We have 2 minutes. 2 minutes? No, you have any time you need. Bus is waiting, no worry.
Thank you, Fran, for refreshing what we have learned today. I will make, since we have the information of the roundtable where I have taken part recent, I'm going to make it short, and I'm going to extract only two sentences. The first one, the first presentation has shown the challenge that transport of vaccines to different points, even to around the world, has been a challenge, and the difficulties. And he has highlighted that the vaccination campaigns have been national, but we have been deploying together in the same places, in the same detachments, and we have had the same problems. I'm sure we have had the same problems. So I consider that you may want to say that maybe we can find a solution for next pandemic or next situation to make it easier to facilitate the delivery of the vaccines. The second presentation has been very interesting about the contribution of military hospital in Brussels to vaccinate people and the difficulties they have. The pharmacy has shown to prepare the syringes, to prepare the stockpiles and everything, which is common to the difficulties or the situations to solve, not to say problems, but the situations to solve in the different pharmacy centers, either in hospitals or in other centers. What we have learned from the French colleague is that the prioritization of people, of personnel who deploy abroad has been very important to fulfill the mission of operational medical support to the armed forces. And they have also shown how the armed forces have contributed to national vaccination system. We have also had 2 more colleagues who have presented the importance of taking into consideration and trying to think of the psychological perspective of the human beings. We are military personnel, but we are also human beings with perceptions, beliefs about vaccines, new medicines or new vaccines, and we have to tackle with that because it's important if we want to convince and if we want that we think that's the best procedure for the health, to preserve the health of the person. And also in Spain, it has been a big advantage, a big step forward, the change of legislation related to nurse and to being able to prescribe the vaccine. So we have been able to get to more people and quicker for the vaccination. Thank you very much for your attention.
I have a present for all of them. Just to say thank you to everybody for your presentations and also for your participation. And just as he said, infectious diseases are an adventure, but please keep away from this virus and enjoy the city. Thank you too much. I'll see you tomorrow.
Please don't forget to leave your translator box in the left of the way.